Finals SAQ86, Pediatric URTI and Daycase surgery. A 5-year-old patient presents for a myringotomy and grommet insertion as Daycase. During your pre-op assessment, you notice that the patient has a nasal discharge. A. Why would it be inappropriate to cancel the operation on the basis of this information alone? There is not enough information so far to determine whether the operation should be cancelled. A runny nose alone is insufficient reason. It is very common in young children and more so in children awaiting this type of surgery. There are consequences to such a cancellation, such as inefficient list usage, wasted time off school for the child, delayed surgery resulting in ongoing hearing issues in the child with negative impact on education, wasted parents' time off for work resulting in financial loss, loss of trust between parents and child with the hospital, especially if surgery later takes place with runny nose still. B. List the features in the history and examination that might cause you to postpone the operation due to an increased risk of airway complications in this patient. Features in history: fever, unwell, loss of appetite, shortness of breath, sore throat, cough, sputum production, purulent nasal discharge, and significant comorbidities such as OSA, severe asthma, and cardiac condition. Features in examination: fever, listlessness, tachypnea, other signs of respiratory distress, purulent nasal discharge, crackles on auscultation, tachycardia, and delayed capillary refill. C. What social factors would preclude this child's treatment as a day case? This includes lack of telephone, poor housing conditions, no private transport, distance more than 1 hour from hospital, and parents unable or unwilling to care for the child post-operatively. Comments: 44.7% pass rate. Majority of candidates did not mention emotional aspects, financial losses, parental work absence, school absence, and inefficient use of hospital resources in the answer. Next, we move on to pediatric airway infections. The preschool child develops 6 to 8 URTIs per year compared to adults 2 to 4 URTI per year. 95% of URTI are secondary to viral causes, with rhinoviruses accounting for 30 to 40% of infections. Chronic runny nose is present in almost 25% of children. Causes include seasonal rhinitis and adenoidal infection. Differential diagnosis of URTI includes infectious and non-infectious. Examples of infectious causes include croup, influenza, epiglottitis, streptococcal sore throat, herpes simplex, bronchiolitis, and pneumonia. Examples of non-infective causes include allergy, vasomotor rhinitis, asthma, foreign body aspiration, and GE reflux. Anesthesia in the presence of an intercurrent URTI increases the risk of complications in younger children, especially those under 1 year of age. Airway hyperreactivity is common after an URTI. In these cases, the least invasive airway possible is the best approach to minimize perioperative respi complications. A history of URTI or other respiratory disease increases the risk of perioperative adverse respi events, such as coughing, breath holding, laryngospasm, bronchospasm, airway obstruction, desaturation, atelectasis, post-extubation stridor, pneumonia, and unanticipated tracheal intubation or reintubation. Pathophysiology of airway hyperreactivity after viral URTI. Viral damage leads to release of inflammatory mediators, which increases the risk of bronchoconstriction. Examples of inflammatory mediators include bradykinin, prostaglandin, histamine, and interleukins. Viral neuraminases inhibit muscarinic M2 receptors on vagal nerve endings, increasing ACH release and leads to bronchoconstriction. Viral inhibition of neutral endopeptidase increases smooth muscle constrictor response to tachykinins. Children determined to have moderate to severe chest infections or systemic effects of infection should have their operation postponed. These will include those with productive cough, purulent nasal discharge, dyspnea, pyrexia, wheezing or crepitations on chest auscultation, parental confirmation that the child is unwell, and signs of viremia or constitutional illness, such as fever, malaise, irritability, reduced appetite, diarrhea and vomiting. The child with a mild URTI is a difficult problem. The history in these cases is crucial. It is important to decide whether the child is at the beginning or at the end of the URTI. Other members of the family or children at school may have already experienced the same infection, and this can provide useful information. The CODE score by Lee et al. 2017 consists of 5 questions: current signs and symptoms, onset of symptoms, presence of lung disease, airway management and type of surgery. Each question has 3 possible choices for an answer, which corresponds to a score of 1, 2, or 5, depending on the level of severity, total minimum score of 5 and maximum score of 25. A higher CODE score would suggest more perioperative risk. At what score cancellations should occur vary from institution to institution based on tolerated risk level. CODE score performs better in younger age group among children 6 years old or less. Some recommend score of more than 10 as a cutoff to cancel operations. The decision to proceed is not always clear and requires careful discussion with the parents. Level of urgency, complexity of surgery, informed consent, good clinical judgment and experience are key factors in these decisions. The risk of perioperative complications is greatest in the presence of acute infection, but remains increased for 2 to 6 weeks after URTI. A child deemed to be post-viral apyrexial with no chest signs and is constitutionally well is probably fit for surgery, even if they have a runny nose. Recommended duration of postponement of op: significant URTI, more than 2 weeks, lower respiratory tract infection, more than 4 weeks, and bronchiolitis, more than 6 weeks. Other relative contraindications for surgery includes less than 1 year old, cared for by less experienced anesthetist, endotracheal tube required for the procedure, child with asthma, and parental smokers. Anesthetic management. Independent risk factors for adverse respiratory events in children with active URTI includes intubation, prematurity, history of asthma or atopy, family members who smoke, airway surgery, presence of copious secretions, nasal congestion, parental confirmation that my child has a cold, and snoring. Pre-op assessment. Clinical assessment is based on history and examination. A child with URTI can be categorized as mild, uncomplicated disease or more severe symptoms. Those with mild URTI have clear rhinorrhea, appear otherwise healthy, and have clear lungs to auscultation and no fever. Most children with mild URTI can be safely anesthetized without significant morbidity, and those children with more severe symptoms should have elective surgeries postponed for at least 4 weeks. Overtly sick children have fever, purulent nasal discharge, productive cough, and are ill appearing with signs of pulmonary involvement. Perioperative adverse respiratory events can be anticipated and are easily recognizable and treatable. Laboratory tests are available to confirm clinical diagnosis of URTI but are seldom necessary, not cost-effective, and may not be practical in a busy surgical setting. Measurement of oxygen saturation is a useful discriminator to detect the child with lower respiratory tract infection. Other investigations to consider includes chest X-ray, white cell count, nasopharyngeal swabs or aspirates. The decision to postpone or proceed with surgery for the child with URTI should be made on an individual basis, considering the presence of risk factors and anesthetist's own comfort and experience in anesthetizing a child with URTI. Ways to reduce risk of adverse respiratory events from URTI. Postponing surgery for all high-risk surgeries such as patients less than 1 year old and are overtly sick, such as those with fever, purulent secretions, productive cough, and ill patients. Postponing surgery that requires intubation and requiring inhalational induction, and postponing airway surgery. If decide to proceed with surgery, to reduce the risk of respiratory events from URTI, involve senior anesthetists, consider pre-op bronchodilators, given 10 to 30 minutes prior to surgery. This has been shown to reduce perioperative respi events. There is benefit of adding inhaled steroid to beta agonists. Consider propofol induction rather than inhalational induction. Induction with thiopenton is associated with higher risk of respi complications. Minimize secretions. The airway should only be suctioned under deep anesthesia. The child should be well hydrated, and a humidifier may be helpful to clear secretions and prevent bronchial mucus plugging. No evidence that glycopyrrolate reduce adverse respi events. Limit stimulation to the irritable airway. Avoid tracheal intubation if possible. LMA or face masks are preferable. Lubricate LMA with lignocaine gel. Adequate reversal of neuromuscular block. Respi complications are higher when neuromuscular blocking agents are not adequately reversed. There is no consensus on optimum depth of anesthesia at which extubation of the trachea or removal of LMA should be done. Many anesthetists would prefer to remove the airway when the patient is fully awake to enable the child to clear secretions and protect their airway. Standard monitoring and adequately trained PACU staff to detect and treat laryngospasm or bronchospasm. Next, we move on to management of respiratory distress in pediatrics. Causes of respiratory distress may be divided into those of upper airway and lower airway. Upper airway causes. Infective cause includes uveitis, epiglottitis, croup, retropharyngeal or peritonsillar abscess. Non-infective causes, foreign body, vocal cord dysfunction, anaphylaxis and tumors. Causes for lower airway includes infective cause, tracheitis, bronchiolitis, pneumonia and empyema. Non-infective cause, asthma, anaphylaxis, hilar tumors, vascular abnormalities, pulmonary edema, pneumothorax, and pulmonary infiltrations, such as fibrosis, oncological and autoimmune conditions. Regarding initial management of child presenting with respiratory distress, this follows an ABCDE pattern as per APLS guideline. Assess the child's response, proceed to life support if necessary. Airway. Oxygen should be ideally humidified, administered whenever possible, unless it may cause agitation and clinical deterioration. Look for chest movement. Listen for breath sounds and evidence of obstruction, such as stridor and stertor, and feel for air movement. Assess respiratory rate, recessions, cyanosis, oxygen saturations, and breath sounds. Attention should be paid to the child's circulation status, conscious levels, and pupils. Look for other signs, such as rash and fever. Focus history. Sudden onset of symptoms suggests foreign body obstruction, anaphylaxis, or trauma. Infections usually have a longer time course, and fever is usually present. A change in voice is suggestive of inflammation or obstruction at the laryngeal or supraglottic level. On examination, exclude complete or life-threatening airway obstruction. Assess respi rate, respi pattern, use of accessory muscles or recessions, breath sounds, presence and character of cough, signs of infection, such as fever, lymphadenopathy and sputum, the child's position, and ability to swallow or any drooling. Assuming that airway obstruction is not present and diagnosis is elusive, useful investigations includes anterior, posterior, and lateral X-ray, CT scan and blood or throat culture and viral swabs. Special considerations. Should tracheal intubation be indicated in a child with respiratory distress, there is no consensus on whether inhalational or IV induction is preferable. Considerations includes clinical expertise, child's condition, likelihood of a difficult airway, and risk of further agitating the child. Advantages of inhalational induction. Slow onset of anesthesia in a sick patient with less chance of causing apnea. Complete airway obstruction will prevent deepening of anesthesia, allowing the child to wake up. It does not require IV access, which may reduce agitation in the child. Volatile anesthetic agents causes bronchodilation and reduces resistance in the respiratory tree. Advantages of IV induction. Rapid induction of anesthesia allows airway reflexes to be overcome very quickly. Familiar technique even for non-pediatric specialists. Depth of anesthesia is not dependent on patency of airway. and 100% oxygen can be administered. Regarding heliox, first a quick recap on Reynolds number. This is a dimensionless index and refers to the ratio of inertial forces to viscous forces, whereby Reynolds number equals density of the fluid times velocity of the fluid times diameter of the tube divided by viscosity of the fluid. Reynolds number is proportional to the radius of airway, average velocity of gas flow in the airway, and the gas density, and inversely proportional to gas viscosity. Turbulent flow occurs when Reynolds number is above 2000, and when Reynolds number is less than 2000, the flow is likely laminar. Narrowed airways will predispose to turbulent rather than laminar flow, as the average velocity in these segments are greatly increased. Failure to maintain laminar flow in airways increases work of breathing. Helium has a similar viscosity to oxygen and nitrogen, but a much lower density. Heliox is a mixture of 79% helium and 21% oxygen, and its low density provides favorable flow dynamics in narrowed airways by keeping the Reynolds number low and hence supporting laminar flow. Next, we will discuss specific conditions. Croup, also known as viral laryngotracheitis. This is often used to describe a range of pathologies includes laryngotracheobronchitis and spasmodic croup, characterized by nocturnal paroxysms of stridor without fever or inflammation. It occurs due to swelling and edema of the epithelial layer of the upper airway. Etiology includes parainfluenza viruses, respiratory syncytial virus, adenovirus, and coronavirus. Presentation: child with croup, age 6 months to 3 years, classically presents with fever, stridor, barking cough, and hoarseness. Nasal congestion and coryza worsens over 48 hours, resulting in respiratory distress and airway obstruction. The degree of stridor determines severity. Signs of severe airway obstruction include stridor at rest, suprasternal, subcostal, and intercostal recessions, and hypoxia. The Wesley Croup score may be used to determine severity of croup. 5 parameters includes chest wall retractions, stridor, cyanosis, level of consciousness, and air entry. Impending respiratory failure has a score of 12 or more. Management. Mainstay of management are supportive therapies, with tracheointubation where indicated. Corticosteroids, such as dexamethasone or budesonide, is effective in the treatment of all severities of croup, with improvement in Wesley Croup score seen as soon as 6 hours after administration. Steroids enable reduced hospital stay and readmission. Optimum dose and route of corticosteroids has yet to be determined. Nebulized adrenaline enables significant clinical improvement 30 minutes after administration. However, improvement is transient. There is no benefit compared with no treatment 2 hours after administration. Next, we shall discuss epiglottitis. Pathophysiology. Unlike the posterior surface of the epiglottis, the stratified squamous epithelium of the anterior surface of the epiglottis is only loosely adherent. In epiglottitis, edema will collect beneath the epithelium on the anterior surface, narrowing the airway and causing stridor. Etiology includes Haemophilus influenza type B, other Haemophilus subgroups, and Streptococcus. Presentation: short history of respiratory distress, drooling, stridor, sniffing posture in an attempt to maximize airway patency. Typically, child is extremely unwell with high fever and odynophagia. Cough is commonly absent. This is a clinical emergency. Management: follow basic principles of initial management of child with respiratory distress, combined with prompt administration of antimicrobial drugs. IV co-amoxiclav 30 mg per kg is appropriate. Respiratory distress may be provoked by attempts at venous cannulation. Thus, it may be necessary to delay antimicrobial therapy and microbiological culture until the airway is secured. Difficult airway management due to narrowing of airway. ENT surgeon should stand by for tracheostomy. Routine intubation of children with epiglottitis reduces mortality rates compared with those managed medically without artificial airway. Intubation is usually required 2 to 3 days before extubation is possible. Criteria for extubation includes demonstrable cuff leak around the tracheal tube, lack of fever, resolved odynophagia and dysphagia symptoms, resolved airway edema assessed using nasolaryngoscopy. Next, we will discuss uveitis. Etiology includes group A streptococcus, Haemophilus influenza type B, trauma, allergy, thermal injury and vasculitis. Presentation: fever, pain, dysphagia and drooling. Respiratory distress is uncommon unless epiglottitis is also present. Swollen erythematous uvula with or without exudate would be expected with an infective etiology. Management depends on the cause. As with all airway infections, follow initial management of child with respiratory distress as mentioned above. Antimicrobial therapy is mainstay for infective uveitis and should be directed by cultures and sensitivity. Next, we will discuss tonsillitis, peritonsillar, and retropharyngeal abscess. Acute airway compromise purely as a result of tonsillitis may occur, but this is rare without associated extratonsillar spread of infection. Etiology includes group A streptococcus, Staph aureus, and respiratory anaerobes such as fusobacteria and prevotella. Pathophysiology: the palatine tonsils lie between the palatoglossal and palatopharyngeal arches and are covered by a fibrous capsule that separates the tonsil from the superior and middle constrictor muscles. Owing to loose connective tissue in this area, a potential space exists bordered by the arches and the superior constrictor. The retropharyngeal space extends from the skull base to the posterior mediastinum, and its boundaries are formed by layers of the deep cervical fascia, lymph nodes draining the nasopharynx, adenoids, sinuses, and middle ear run in this space. Ordinarily, peritonsillar infection follows tonsillitis and advances through local cellulitis to form organized abscesses. A much rarer disease process, retropharyngeal abscess is associated with URTI, which may be the precursor for abscess formation in up to 50% of cases. Retropharyngeal infections may also arise from oropharyngeal trauma or dental disease. Presentation: owing to the proximity of structures involved in the similar disease processes, the presentation of these infections are similar. For peritonsillar abscess, the patient presents with severe unilateral sore throat, fever, change in voice, trismus, swollen tonsils, and deviation of uvula or palatal structures. Retropharyngeal abscess may present with fever, dysphagia, change in voice, neck swelling, and if severe, drooling, torticollis, trismus, airway obstruction, and chest pain, indicating mediastinitis. CT with contrast should reveal the site of infection, but may not be necessary or sensible in a child with respiratory distress. Management: follow principles of initial management in child with respiratory distress mentioned above. Other mainstays of management includes surgical drainage, antibiotics, and supportive care. Antibiotics should be guided on local policy and should cover gram-positive bacteria and anaerobes. Regarding peritonsillar abscess, surgical removal of tonsils in the acute stage is controversial due to high risk of bleeding. If pus has formed, consensus seems to be in favor of tonsillectomy to avoid the risk of local vascular erosion and aspiration following spontaneous rupture. Regarding airway obstruction in this context, it may be challenging to secure the airway due to anatomical distortion. Retropharyngeal abscess may make glottis hard to visualize, and any attempt at securing the airway should occur with ENT surgeon on standby. Inhalational induction has been suggested, and cuff tracheal tube helps prevent soiling of lower airways. Regarding bacterial tracheitis, this is an invasive exudative bacterial infection of the trachea caused by Staphylococcus, Streptococcus, or H. influenza. Patient presents with cough, stridor, pyrexia, rapidly advancing history, sepsis, and airway obstruction. Management: intubation and mechanical ventilation is indicated in airway obstruction and rapid clinical deterioration. Intensive care management and supportive therapies include regular suctioning of tracheal secretions. Endoscopy to remove pseudomembranous exudates may significantly improve symptoms and enable specimens for culture. Rigid bronchoscopy under GA may be possible in the spontaneously breathing child before tracheal intubation and transfer to intensive care, but may be very challenging in the sick or hypoxemic child. If the child is compromised by any attempts at bronchoscopy and airway toilet, they should be intubated and airway debris removed via the use of suction catheters. Antibiotic selection should follow local guidance. Suitable agents include coamoxiclav and ceftriaxone. Ensure coverage for gram-positive organisms. There is no evidence to support use of glucocorticoids in the treatment of bacterial tracheitis. Next, we shall discuss Daycase surgery. Regarding organization, a surgical daycase is a patient who is admitted, operated upon, and discharged on the same calendar day. The surgery must have been planned as a day surgery. Booking potential daycase patients via an inpatient pathway can result in patient cancellation due to lack of availability of post-op bed, which would not have been required if a day surgery pathway was planned from the outset. Organization is the key to efficient, good quality day surgery and requires close cooperation between all agencies, including surgeons, anesthetists, day unit staff, GPs, patients, and their carers. Regarding facilities, an efficient organization requires ring-fenced theaters and ward space. Day surgery can be managed successfully in a variety of hospital configurations. However, day cases on inpatient wards and theaters have a higher admission rate and will suffer cancellation when there are bed shortages. Self-contained units with their own facilities, but within an acute hospital, offers the best option. Regarding escalation, it is essential that day surgery facilities will not be used to accommodate overnight patients at times of hospital escalation. At times of escalation, it is even more important that day surgery unit continues to function efficiently and hence enable the majority of elective surgery to proceed uninterrupted. Regarding staffing, adequately trained and experienced staff should perform daycase anesthesia and surgery to minimize unplanned admissions. The day surgery environment provides many opportunities for training of junior staff, but supervision and guidance from senior clinicians are essential. The unit should be staffed with nurses and operating department practitioners who are in themselves expert day surgery practitioners invested in the success of day surgery team. Regarding day surgery procedures, the British Association of Day Surgery has produced a directory which details over 200 procedures now deemed appropriate to be undertaken on a daycase basis. Day surgery is no longer confined to minor procedures, but embraces the majority of elective surgery and a large percentage of urgent surgery. There is no time limit for surgical duration. Consideration must be given when scheduling and operating theatre lists to potential post-op recovery times for more complex surgery, such that longer procedures will usually be undertaken in the morning or early afternoon. For a procedure to be appropriate for day surgery, the following criteria must be met. It should be possible to control pain with simple oral analgesia, supplemented if appropriate by regional anesthesia. The patient must be able to eat and drink post-operatively, and the patient must be able to mobilize post-operatively. Examples of day surgery procedures: laparoscopic hysterectomy, vaginal repair, vaginal hysterectomy, laparoscopic fundoplication, laparoscopic nephrectomy, prostatectomy, and laser resection of prostate, mastectomy, all non-reconstructive breast cancer surgery, endovascular aneurysm repair, total hip, knee or shoulder replacement, appendicectomy, testicular torsion repair, hot laparoscopic cholecystectomy, and laser of ureteric stones. Regarding emergency day surgery, moving emergency surgical procedures to an ambulatory pathway confers many benefits. Where possible, the patient should be seen and assessed in a surgical assessment unit and discharged home to wait in their own homes rather than a hospital bed for their procedure. Traditionally, many patients awaiting urgent surgical procedures are not prioritized for the emergency list and end up being fasted for a number of days, occupying surgical beds until a slot becomes available. There are a variety of opportunities for urgent patients to be scheduled. For example, dedicated first slot on emergency list, planned slots on elective day surgery list, running dedicated emergency day surgery list, and proactively filling any vacant slots on elective day surgery list or vacant list with emergency day surgery patients. Patient preparation and optimization for day surgery. Patients should follow a sequential pathway and undergo pre-op assessment by experienced day surgery nursing staff according to set Daycase criteria. Nurses should have the support of consultant anesthetists whom they can approach for advice. Ideal practice is where patients attend assessments at the hospital on the day of their surgical outpatient appointment. Some patient groups can undergo telephone assessment, particularly those who are young, fit, and with no medication, and undergoing procedure that does not require specific tests. Successful day surgery requires anesthetic departments to consider patients who fall outside traditional guidelines and judge if they can be made fit for day surgery. Protocols can be used for pre-op investigations, but these should be kept to those absolutely essential for the surgery, as very few investigations in day surgery pathway alter the management. Clear instructions must be given to the patient regarding what will happen on the day of surgery, what they need to bring on the day of surgery, and organization of someone to take them home and care for them post-operatively. Clear written information should be provided. Most cancellations on the day of surgery can be avoided by careful pre-op assessment by experienced staff. Daycase patient selection criteria. Criteria needs to be agreed with the anesthetic department and vary according to the day surgery unit setting. For example, more challenging patients and procedures can be undertaken where the unit is integrated into a hospital with all support services. Stand-alone units on isolated sites will need more conservative criteria. However, patients deemed inappropriate for surgery in those off-site units may still undergo day surgery pathway via the main hospital facility. Day surgery is no longer reserved purely for the fit and healthy. Most patients with stable medical conditions are appropriate for day surgery. Many complex patients will do better in a Daycase environment if they are managed appropriately, such as insulin-dependent diabetics, severe COPD patients, patients on dialysis, and those who are suffering from epilepsy. If a patient with unstable medical disease is presented for surgery, they should have their condition optimized before proceeding with surgery and can then often be managed via a Daycase pathway. Always try to remember these two questions. What can we do to enable this patient to be managed as Daycase? Would anything be done differently if the patient were to be treated as an inpatient? If the answer to the question is no, then day surgery is probably the optimal pathway. Regarding age, there is no upper age limit. Physiological fitness should be considered rather than chronological age, remembering that the elderly are usually better managed in their home environment. Babies as young as 6 weeks can be managed on a Daycase basis. However, exclude premature infants less than 60 weeks post-gestational age due to risk of sudden infant death syndrome, SIDS. Regarding BMI, there is no longer any BMI limit for day surgery. With the presence of appropriately skilled staff and equipment, even morbidly obese can be successfully managed as Daycase. This can be ideal as early mobilization reduces the risk of complications. Assessment should include questions about OSA as well. Avoid opioid medication if OSA is present. Regarding transport and social support, all patients must be escorted home by a responsible informed adult, and in most cases be adequately supervised during their recovery at home for a minimum of 24 hours. Some units employ carers for patients without home support to enable them to be treated as day cases. There is increasing acceptance that patients undergoing more minor surgery who are judged appropriate at pre-op assessment and wish to go home alone are permitted to do so, and this is preferable to an overnight hospital admission. However, patients must have suitable home conditions, adequate toilet facilities, telephone readily available for advice in an emergency. Patients should not drive, cycle, or operate machinery or consume alcohol 24 hours after anesthesia. Regarding geography, the patient should live within 1 hour traveling distance from a hospital, which can treat the complications resulting from the surgery. This may not always be the hospital where the surgery was performed. Regarding conduct of daycase anesthesia, principles of day surgery anesthesia includes pre-medication with oral analgesia, use of short-acting anesthetic agents, avoidance of emetogenic medications, use of multimodal analgesia, use of short-acting opioids for rescue analgesia if required, and good post-op analgesia. Preoperative. Avoid sedative pre-medication if at all possible. If necessary, usually only for patients with behavioral issues, oral midazolam up to 0.5 mg per kg in sweet fruit juice as it tastes awful. Regarding antacid drugs, routine use is unnecessary. However, in those with history of regurgitation, ranitidine or omeprazole is appropriate. Pre-op oral analgesia includes paracetamol and NSAIDs unless contraindicated. Patients should be encouraged to remain warm and hydrated preoperatively. Delaying changing from street clothes to theatre gowns until absolutely necessary minimizes hypothermia. Encouraging liberal consumption of water preoperatively minimizes rates of PONV. Perioperative management. Short-acting agents should be used. Tiva is ideally suited to day surgery. However, many units have success with sevoflurane. For larger procedures, incremental fentanyl in divided doses is appropriate. IV morphine should be avoided. Consider NSAIDs if not already given. Local anesthesia for every suitable patient or surgery. Whenever possible, use an LMA and avoid intubation and muscle relaxants. Patients should be kept warm and hydrated. This reduces incidence of dizziness and PONV and aids recovery. Avoid agents that can contribute to PONV, such as nitrous oxide, and long-acting opioids such as morphine. Antiemetics are not indicated routinely, especially if emetogenic triggers are avoided, but should be reserved for treatment of any PONV or for prophylaxis in patients with history of PONV or surgical procedures with high incidence of PONV. Post-op management, balanced analgesia with paracetamol, NSAIDs, local anesthesia, and short-acting opioids as appropriate. If more analgesia is needed, it is imperative to use it early and consider IV fentanyl boluses. Give oral morphine or other agents such as tramadol if stronger analgesia is required. Remember that morphine in doses above 0.1 mg per kg increases admission rate. Antispasmodic agents such as hyoscine and physical therapies such as hot water bottles may help, particularly for lower abdominal cramps following gynecological surgery. Regarding PONV management, a multifactorial approach should be used. APFO scoring system may significantly overestimate the risk of PONV if anesthetic techniques described above are employed. Patients experiencing PONV must be actively managed before discharging home. For high-risk patients, consider LA techniques, TIVA if GA is used, avoidance of opioids, multimodal analgesic therapy, good hydration, minimal fluid fast, dexamethasone in combination with cyclizine or 5-HT antagonists are effective prophylactic agents. This is an approach that works well and leaves only a small number of patients requiring rescue treatment postoperatively. Regarding the fourth consensus guidelines for the management of PONV by Gunn et al. In 2020, risk factors for PONV in adults, female sex, history of PONV or motion sickness, non-smoking, younger age, general versus regional anesthesia, use of volatile anesthetics and nitrous oxide, use of post-op opioids, high duration of anesthesia, type of surgery such as cholecystectomy, laparoscopic, and gynecological surgery. Conflicting risk factors includes ASA status, menstrual cycle, level of anesthetic experience, and perioperative fasting. Disproven risk factors for PONV includes BMI, anxiety, nasogastric tube, migraine, and supplemental oxygen. Risk factors for PONV in children includes age 3 years old or more, history of PONV or motion sickness, family history of PONV, post-pubertal female, strabismus surgery, adenotonsillectomy, otoplasty, surgery lasting 30 minutes or more, use of volatile anesthetics, use of anticholinesterases, and use of long-acting opioids. Strategies to reduce baseline risk includes avoidance of GA by the use of regional anesthesia, use of propofol for induction and maintenance of anesthesia, avoidance of nitrous oxide in surgeries lasting over 1 hour, avoidance of volatile anesthetics, minimization of intraoperative and post-op opioids, adequate hydration, and use of sugammadex instead of neostigmine for the reversal of neuromuscular blockade. Regarding adult PONV management, risk factors includes female sex, younger age, non-smoker, surgery type, history of PONV or motion sickness, and use of opioid analgesia. Measures for risk mitigation: minimize use of nitrous oxide, volatile anesthetic, and high-dose neostigmine. Consider regional anesthesia, use of opioid sparing and multimodal analgesia, i.e. enhanced recovery pathways. Risk stratify the patient. For those with 1 to 2 risk factors, give 2 prophylactic agents. Patients with more than 2 risk factors, give 3 to 4 prophylactic agents. Regarding rescue treatment, use antiemetic from different class than prophylactic drug use. This table lists antiemetic doses and timing for prevention of PONV in adults. Pharmacologic combination therapy for adults and children. For adults, options includes 5-HT receptor antagonist with dexamethasone, 5-HT receptor antagonist with apripitan, 5-HT receptor antagonist with droperidol. Other combination therapies such as ondansetron plus haloperidol, haloperidol, dexamethasone and ondansetron, ondansetron and betahistine, ramosetron and gabapentin, midazolam and ramosetron. Other anti-dopaminergic combination therapies includes dexamethasone with haloperidol, metoclopramide with dimenhydrinate, amisulpride plus 1 non-dopaminergic antiemetic, and haloperidol plus midazolam. Other combinations includes propofol with dexamethasone, dexamethasone with dimenhydrinate, gabapentin with dexamethasone, apripitan with dexamethasone, acupoint stimulation, and pharmacoprophylaxis. Combination therapy for children includes ondansetron plus dexamethasone, or ondansetron plus droperidol, or tropisetron plus dexamethasone. Regarding pediatric PONV management, risk factors includes preoperative risk factors, age 3 years old or more, history of PONV, family history of PONV, and post-pubertal female. Intraoperative risk factors includes strabismus surgery, adenotonsillectomy, otoplasty, surgery 30 minutes or more, volatile anesthetics and use of anticholinesterase. Post-op risk factors, use of long-acting opioids. Risk stratification: no risk factors, low risk. None or 5-HT antagonists or dexamethasone should be given as prophylaxis. Those with 1 to 2 risk factors, medium risk, give 5-HT antagonists plus dexamethasone. Those with 3 or more risk factors, considered high risk, give 5-HT antagonists with dexamethasone and consider TIVA. For rescue treatment, use antiemetic from different class than prophylactic drug such as droperidol, promethazine, dimenhydrinate, metoclopramide, and acupuncture. Doses for antiemetics are listed here for pediatrics. Regarding regional anesthesia in daycase surgery, The increased use of ultrasound enables many procedures to be undertaken purely under regional anesthesia with huge efficiency gains. It is reasonable to discharge patients with a working plexus block, allowing the benefit of prolonged post-op analgesia. The patients require special instructions on the care of the anesthetized part to avoid damage. This would include sling for patients with brachial plexus block. Regarding local anesthesia infiltration, surgeons should be encouraged to use liberal infiltration of LA for any incision. For many procedures such as inguinal hernia repair or breast cancer surgery, surgical infiltration is as effective as regional anesthesia. It can also be more efficient and associated with fewer complications. Regarding some specific blocks, field block performed by the surgeon provides excellent analgesia and may obviate the need for general anesthesia. For example, this can be used for inguinal hernia surgery with LA infiltration under direct vision. Attempt at ilioinguinal nerve block by anesthetist has high incidence of femoral nerve block and subsequent unplanned admission due to difficulty in mobilizing. Regarding spinal anesthesia, shorter acting spinal agents such as 1% chloroprocaine results in 40 to 60 minute duration of block, and 2% hyperbaric prelocaine resulting in 90 to 120 minute duration of block have revolutionized the ability to provide day surgery spinal anesthetic service with rapid post-op mobilization. If shorter acting agents are unavailable, consider reduced dose spinals such as 5 to 7.5 mg of bupivacaine. This allows similar onset of anesthesia with less motor block and shorter discharge time compared with standard doses, 4 versus 6 hours. Bupivacaine 0.25% has become widely used for Daycase joint replacement surgery. However, it is important to use the racemic mixture rather than levobupivacaine, which is associated with more patchy and unreliable block when used at lower concentrations. Avoid femoral blocks due to difficulty in mobilizing postoperatively. When appropriate, saphenous nerve block alone is an alternative option. Regarding discharge for Daycase patients, discharge drugs. All patients should have a supply of suitable oral post-op analgesics at home or be given to them on discharge. There should be procedure-specific analgesic protocols to ensure consistent prescribing between clinicians. Audit of post-op pain scores should be undertaken to ensure the protocols are appropriate. This table shows an example protocol for Daycase surgery take-home analgesia. Expected pain, none. Example procedure, cystoscopy. Analgesia, none. Expected pain, mild. Example procedure, prostatic biopsy. Analgesia, PCM 1 gram QID. Expected pain, moderate. Examples, dental extraction, mastectomy and arthroscopy. Analgesia, PCM 1 gram QID. Ibuprofen 400 mg QID. Expected pain, severe. Examples, laparoscopic cholecystectomy, laparoscopic hysterectomy, and hernia repair. Analgesia, cocodamol, ibuprofen, and macrogol. Discharge criteria, stable vital signs, fully awake and orientated, tolerating oral fluids, passing urine is only essential after specific procedures such as urology or gynecology or spinal or caudal anesthesia, patient able to ambulate, pain and nausea well controlled, minimal bleeding or wound drainage. This is the discharge checklist for day surgery by British Association of Day Surgery. Criteria includes vital signs stable, orientated to time-place person, pass urine if applicable, able to dress and walk when applicable, oral fluids tolerated if applicable, minimal pain, minimal bleeding, minimal nausea and vomiting, cannula removed, responsible escort present, has carer for 24 hours post-op, written and verbal post-op instructions given, know who to contact in an emergency, follow-up appointment, removal of sutures required, referrals made, dressing supplied, patient copy of GP letter, carbon copy of consent, sick certificate, take-home medications, information leaflet for tablets, whether post-op phone call is required. Regarding specific discharge criteria for regional techniques, spinal anesthesia, full recovery of motor power and proprioception, and patient has passed urine. For regional blocks, understanding of protection of partially blocked limb, instructions regarding when the block should have regressed, and who to contact if it has not, adequate mobility on crutches if required. Regarding discharge organization, written and verbal discharge information must be provided. It is essential that patients are given contact number of someone in the hospital should they require advice. This may be the day surgery unit within opening hours and either surgical ward or senior surgical nurse overnight. It is not appropriate for patients to be directed to out of hours, GP services or emergency departments. The most common reasons for overnight admission includes patient not fulfilling discharge criteria before the unit closes, observation after surgical or anesthetic complications, unexpected more extensive surgery, and uncontrolled pain or PONV. Overall, unanticipated admission rates will depend upon surgical case mix undertaken. With increasingly complex procedures entering day surgery arena, timely discharge is more challenging, and consideration to the development of a procedure-specific anesthetic guideline is required. For example, for joint replacements, hysterectomy, laparoscopic, cholecystectomy, and tonsillectomy. Regarding follow-up, audit, and benchmarking, patient follow-up is an essential part of day surgery pathway to ensure patients are comfortable and satisfied post-op. Most effective method is via post-op telephone service. Structured questionnaire should cover post-op pain score, PONV score, patient satisfaction, satisfaction with day surgery pathway, and requirement for any post-op advice or support. This service provides detailed audit information and analysis which drives continuous improvement. It also provides opportunity to support the patient should they have any queries or concerns. This flowchart by Quamby D et al. In 2014 lists key factors for a successful Daycase pathway. These are my references. Thank you.